Hello, I'm Mark Sands, the Vice Chairman of Clinical Operations and Quality of the Imaging Institute of Cleveland Clinic. This afternoon, I'm going to discuss with you our experience lowering CT doses at Cleveland Clinic, the successes that we've had, and the challenges we faced. The objectives of this talk are to discuss the background and initial steps of change associated with developing a de novo radiation dose consciousness among practitioners, to outline the challenges of scope and heterogeneity across a large enterprise, and to highlight the successes and persistent opportunities of program development. Cleveland Clinic Health System consists of a main academic type hospital, 9 community hospitals, and 12 family health centers. We operate additional facilities in Florida, Nevada, and Toronto. Cleveland Clinic Health Systems operates 65 different diagnostic CT scanners representing the work of 4 different vendors and 15 different models of those vendors. We have innumerable fluoroscopy and cardiac catheterization laboratories. We provide adult and pediatric subspecialty services across the continuum of care. At the beginning of the millennium, we faced a non-uniform practice pattern across an enlarging health system. Our CT protocols and preferences reflected the medical practice patterns of the sites in which we operated. Ohio as a state had basic state regulation primarily emphasizing fluoroscopic modalities with some basic regulation of CT modalities. There was an underdeveloped medical physics group which had not reached its current size, and at the time there was virtually no public or media scrutiny of our practices as radiologists. We also found ourselves in the midst of the CT slice wars. The original CT scanner introduced in the 1980s generated the image you see, and that was rapidly replaced with the image you now see at the expense of large amounts of radiation to make this type of image. At the end of the first decade of the new millennium, Cedars-Sinai Hospital in California made the news with unintended consequences of some of these powerful imaging devices. Cleveland Clinic anticipated some of the changes that began in that first decade of the millennium. In 2006, we organized the Quality and Patient Safety Institute with representatives of each division of service at Cleveland Clinic. In 2007, the Division of Radiology began to address issues with quality of care with fluoroscopic imaging modalities. In 2008, changes in practices around CT were begun, and in 2010, a big bang of sorts involving the efforts of quality, physicists, radiologists, and technical staff began to change the way we practice computed tomography. Any new program involves rigid risk assessment, as all things cannot be changed at the same time. CT was at the top of our list because of the frequency and diversity of protocols that were practiced. Pediatric protocols were particularly of interest to us. Fluoroscopy, because of issues of acute injury from overexposure, was also at the top of the list, and all pediatric imaging was inspected. Initial attempts to begin reforming the practice of CT were begun in the following ways. We created pediatric protocols by subspecialist pediatric radiologists for use throughout the health system. This, however, was met by suboptimal acceptance as general radiologists could not always interpret the lesser quality images that were obtained from changing the CT technique. We also worked to instill consciousness through actively recording dose and dictated CT reports. Again, here there was some reluctance on the part of the radiologists, who often did not understand the benefit that this would confer upon the patient or their report. Attempts to mine the dictated reports for the CT dose data were often inaccurate and incomplete, as incomplete data and voice recognition errors were often seen. We also began a concerted educational effort that will be discussed in a few minutes. Over time, the effort matured. We began to optimize and standardize CT protocols across the enterprise. We methodically began to extract the CT dose information both from reports and from the radiology information system to monitor outliers. We reviewed dose data quarterly with a newly formed CT committee, and we set goals and employed short-cycle data review to manage to various targets that were set. The active CT dose monitoring and reduction program really began in earnest in June 2008 with documentation of fluoroscopic time and radiation dose for fluoroscopy-based procedures and the recording of CT DLP and CT reports. Dose monitoring began in February of 2009 and targets were met for each type of CT exam. Dose reduction practices started in August 2009 and involved pediatric imaging weight-based algorithms, which were started on the main campus and eventually rolled into the regional practice. Cardiovascular imaging developed its own algorithms for vascular CT angiography. Abdominal imaging began evaluating weight-based algorithms in conjunction with medical physics. Optimization of protocols to meet dose targets were begun throughout the health system, and COMET training for technologists and physicians, an online educational resource, was begun in October 2010. This is the timeline that highlights those developments. Due to the diversity of CT scanners, protocol optimization had to be constructed by vendor-specific and model-specific practices. Protocols were grouped into pediatric and adult bins. The protocols were tailored to patient body habitus. They were weight adjusted for abdominal and pelvis size, adjusted for the size of the chest, and age adjusted for pediatric brain and sinus studies. Our original protocols all met ACR specification. However, in practice, when the data was mined from the initial attempts in 2010, several studies were seen to outlie the normal expected dose range. Deeper dives into both the pediatric and adult data suggested that some of this information was difficult to interpret based on how we were doing the screening. Also, we thought part of this would be contributed to by patient body size. The same was true for adults. At Cleveland Clinic, we noticed that some of this discrepancy might be explained by patient body habitus. This chart, obtained from CDC data, demonstrates the increased prevalence of patients with greater than a body mass index of 30 over time. When we reviewed our data, and our outliers in particular, we noticed that there was correspondence between the size of the patient and the amount of dose that they obtained. By this point in 2010, an enterprise-wide initiative for the Imaging Institute was begun. The focus was to reduce variations in dose and image quality. It was a complex endeavor. Again, more than 60 scanners of more than 5 vendors and 2 to 6 models per vendor were involved. There were 50 to 70 protocols per scanner and 11 scan parameters per protocol. Modifications by authorized lead technologists under the direction of medical physicists were the only ones that were permitted. Once changed, they could not be changed by a radiologist. Quality control processes were in place to make sure that these were checked on a routine basis. CT protocol optimization was chosen based by priority, with pediatric patients at the top of the list, high-dose studies such as CT brain perfusion, adult abdomen and pelvis studies, which represented a large volume and perhaps the largest volume of studies, routine brain studies, chest and pulmonary embolism studies, as well as cardiac exams, were put at the top of the list. A web-based protocol access was developed. All standardized protocols for different vendors and models were easily accessible through a centralized protocol portal in the intranet. Enterprise CT Dose Committee, joined by radiologists, lead CT technologists, and physicists, met quarterly to review the protocols and adjust as needed. These are examples of the website that we maintain to direct radiologists and technologists to the appropriate protocols for patients appearing for imaging studies. These are some of the pediatric and adult protocols that we use routinely in this high-risk group. You will notice in these slides that doses have been reduced either by age or by body weight, soon body girth in pediatrics, chest diameter for chest protocols in adults, and weight for abdominal protocols in adults. The CT dose education module that I referred to will be demonstrated on the next slide. Training is an integral part of CT dose reduction effort. A web-based training module is available for all radiologists and technologists. The module consists of radiologist-specific and technologist-specific components. These are required for annual recertification. The link is available on the Cleveland Clinic intranet, and content appears such as this with an examination at the end of the module. Once the protocols were developed and locked down to the individual scanners across the Cleveland Clinic health system, it was important to go back and verify that they were truly implemented. It was important to discover any outlying values and to investigate their cause. CT dose monitoring was required to ultimately fulfill the responsibility to report in near real time to radiology and hospital leadership, set targets, manage results, and make important decisions. The early CT dose management results are shown on the following slides. Much of this data was extracted manually from dictated reports and from early entries into the radiology information system. Improvements in both adult and pediatric CT dose trends were seen but were inconsistent. This is specifically within the first 2 quarters of 2011 for pediatric examinations and for adult examinations. In the instance of adult studies, the gains were not immediately visible. Further, this information could be displayed by our sub-institutions within the Cleveland Clinic health systems. Each hospital would demonstrate the number of studies within appropriate dose length product specifications and those that were not. In this slide, indicating pediatric head CT results, one hospital, indicated by the green arrow, consistently had subpar results. In short order, this hospital stopped scheduling pediatric studies while the adult studies remained within specified parameters. Dose outliers for both adult and pediatric brain CT studies were identified, and work to consistently reduce their occurrence across Cleveland Clinic Health System through CT protocol standardization and CT dose awareness was begun. Abdomen dose was normalized by patient weight to see clear trend. Patient weights were entered manually into the radiology information system for Siemens, GE, and Philips scanners. With these further improvements, the full range of 2011 results were seen, and marked improvement noted. The same was true for pediatric studies. An improvement to our practice was begun in January 2011. We retained an outside company to pull dose reporting pages directly from the PACS system. For scanners with only images of dose reporting pages, optical character recognition was used. For scanners with DICOM dose structured reports, the information was extracted directly from the DICOM tag. Other information such as scan parameters and patient weight were also extracted from the DICOM tag when available. Chest, abdomen, and pelvis doses were adjusted by patient weight and could vary by more than 5 times due to patient weight differences. This is the header page from Primordial, the company we engaged to extract the information from the DICOM headers. You will see that there are columns to tally the types of exams by body region, the number of outliers, and the percentage of successfully arranged examinations. In order to compare to known CT dose references, these were the standards that were selected by the enterprise-wide CT committee based on ACR dose recommendations. The extracted data was then compared to these standards, and the results displayed graphically. Over the course of a 2-year period, there was significant reduction in both adult and pediatric outliers for DLP measurements when measured to the ACR recommendations. In addition, this data could be abstracted and displayed as a formatted chart based on the site of practice within the Cleveland Clinic Health System and the number of outliers displayed on a routine basis as part of that site's ongoing assessment. The Joint Commission has mandated in their Sentinel Event Alert, issue number 47, that radiation risks of diagnostic imaging need to be accounted for. They emphasize the right test, the right dose, effective processes, safe technology, and the development and maintenance of a safety culture. At Cleveland Clinic, we began our own gap analysis to address possible shortcomings in all of these areas. I'd like to also mention the Image Gently campaign, an initiative of the Alliance for Radiation Safety in Pediatric Imaging. This is the represented work of 62 medical organizations. In addition, the pediatric section of the Imaging Institute began their own campaign called X the Dose to reduce and manage radiation related to all imaging within Cleveland Clinic Health System. The committee members consisted of radiologists, physicists, clinical managers, and technologists, as well as their clinical partners. Beyond the efforts discussed in CT, additional efforts centered around eliminating entire babygrams from the Epic CPOE system so that these could not be ordered by services at any point, providing patients their own gonadal shields at the bedside, reducing the number of full extremity x-rays for patients presenting with orthopedic complaints, and reducing the number of acute abdominal series x-rays being performed within the emergency department. In summary, the challenges to providing a comprehensive radiation safety program centered on CT imaging are as follows. It doesn't all have to happen overnight. We follow a practice of relentless incrementalism, building upon small advances that occur on an ongoing basis. This journey for us has occurred over the course of several years. In practice, there are sometimes inconsistent program commitments that are made. This commitment, however, is significant. There are impediments to CT dose monitoring, which include the lack of common terminologies between CT vendors and the lack of standardized dose reporting pages. There are also insufficient CT scan parameters currently transferred into the public DICOM tags. These issues should be addressed by related medical device groups and improved in the future. In summary, the lessons learned are as follows. Large institutions with a variety of CT scanning equipment and practice environments should pursue a reasoned, risk-adjusted approach to CT dose management. Protocol optimization should be done based on the assessed priorities of the organization. Protocol standardization should be implemented by a dedicated group and verified by radiologists and physicists before clinical use. In comparison to selected target values, outlying results should be monitored routinely and addressed promptly. And finally, education of radiology technologists and radiologists is essential and should be regularly updated. I'd like to acknowledge the contributions of the following people with material presented in this talk. Thank you.